Now, it is my great pleasure to introduce Professor Arnold Monto, who has travelled, I think, probably many parts of the world to reach us here, but indeed is the Thomas Francis Collegiate Professor at the University of Michigan School of Public Health. His major focus of work has been on the epidemiology, prevention and treatment of acute infections in the individual and in the community. And he led studies of respiratory infection in Tecumseh. I'm very pleased that I can say Tecumseh because not everyone necessarily pronounces that right. A landmark study of illness in the community, and is now updating those observations in Michigan households and children. So he's incredibly expert in assessing efficacy of various types of influenza vaccines and prophylaxis, has been a member of advisory councils with the NIH, past president of the American Epidemiologic Society, and the Alexander Fleming Award recipient from the Infectious Disease Society of America. And I was very honoured to jump on the CDC website recently and see that there's also been an award in Professor Monto's name for outstanding understanding of epidemiology, exceptional contribution to epidemiology of an understanding of influenza. So that's another great honour for Professor Monto. So please, we welcome you, Professor Monto. We look forward to hearing from you today.
Thank you so much. It's a pleasure to be here and to talk to a country which has experienced influenza since the great influenza of 1918 and even before that time, and has had a leading role along with a couple of other major countries in thinking that influenza is a serious illness. Much of the world, much of Europe really doesn't see the threat of influenza as we do. So I'm going to start at the start in terms of talking about influenza vaccine effectiveness and look at the first trial of influenza vaccine. And it's very interesting that it took place at the University of Michigan in 1943 in the middle of the Second World War, where troops were being officers to be were getting their university education, because at that time you couldn't be an officer without being a gentleman, and you weren't a gentleman in the United States unless you had a university degree. So the trial actually was done there, and it was a vaccine that was produced in a very similar in eggs that were later inactivated the virus and formalinized. So it really hasn't changed, the vaccine, since that time, except being more potent and being more concentrated. So what did the outbreak look like? And this is what the outbreak looked like. And in terms of effectiveness, which they didn't calculate at that time, it was about 70% effective in the young adult university population. But what is even more interesting, and you notice the author of the publication is Salk and Francis, and Salk used the influenza virus inactivation method to develop the later polio vaccine. But what is even more interesting is they were doing HAI tests at that time, and the frequency of illness, as you can see, went down as hemagglutination inhibiting antibodies went up, both in the vaccinated and in the unvaccinated. It's not easy to see this from the rest of the chart, which is from the original publication. And the question I'm going to raise at the very end is, how far have we really gone since 1943 in terms of our ability to prevent influenza by vaccination? Now, the U.S. Army, the U.S. military conducted trials of an activated vaccine every year up to 1969, when they had their budget cut and didn't do placebo-controlled trials anymore, and it was taken over by the National Institutes of Health. And this is where the now infamous 70 to 90% effectiveness of influenza vaccine comes from. Now you have to look at the methodology they use, and you can see a poorly matched year where didn't look all that good. You have to look at the methodology they used. They were not, because they didn't have PCR tests, they were isolating virus in eggs. They basically used serology to determine what the outcome was, and looked at the serology in the vaccinated, and looked for rise in antibody titer, and looked at the serology in the placebo, in the control individuals for rise in antibody titer, and calculated effectiveness from that point. And during one of our clinical trials, we just did a very simple thing and looked at the frequency of rise in titer, and these are PCR confirmed illnesses, and you can see the bias that this does. If you have a high antibody titer as a result of receiving inactivated influenza vaccine, you do not get a rise in titer. So this was a systematic bias overestimating the effectiveness of the vaccine. It was working, but it certainly was not 90%. Now we have live attenuated vaccines. And I'm going to talk a little bit about live attenuated vaccines because there's been a recent approval by the ACIP of using live attenuated vaccines again. And there are actually two kinds of live attenuated vaccines being used in the world. The one that the Western world uses is based, was actually developed by my colleague, John Masab in Ann Arbor. They're temperature-sensitive vaccines. They are attenuated, and they are grown in specific pathogen-free eggs. Now, this is the way they used to be made. They used to co-infect cells and really try to get a hemagglutinin and neuraminidase from the wild parent to the attenuated backbone. And now they use reverse genetics. And that's one of the questions is something happening now with the reverse genetic procedures that are used to develop the attenuated vaccine? Because remember, a live attenuated flu vaccine is different from any other live attenuated vaccines because it needs to be updated on a yearly basis. A regular a measles vaccine does not need to be updated, and these vaccines need to be updated. Now, this is the classic trial of live attenuated vaccine in which they looked like for type A was close to 100% effective, and type B a little less, and it was children under 6 years of age who had not been previously vaccinated, which is probably part of the story of what's going on in the US. And the next year, there was a mismatch. And the vaccine worked well against the A. Sydney virus. Never noticed it was an A. Sydney virus when Wuhan was in the vaccine. And this was a major mismatch. And it seemed to work in a drifted environment against a drifted A H3N2 virus. Then they did another study and showed that the vaccine was superior in young children, again, under 6 years of age. And I won't go through the details. Everything that I'm talking about is published. And if you're interested, you can go and look at the papers. But there was superiority with the two strains against inactivated in young children. You can't say what the absolute efficacy was because there was no placebo group. They were comparing live attenuated with inactivated vaccine, no placebo group. And this is relative efficacy, which we're going to come back to shortly. And then there was a study in adults. And this is the study in which the vaccine was licensed in adults. And the only endpoint, they had no virologic endpoint. This is all clinical. And the only endpoint that looked different was severe febrile illness. The primary endpoint was febrile illness, and it missed the primary endpoint, but the vaccine was licensed in the United States anyway, up to age 49. We thought, well, this vaccine should be working better in adults than in young children. We designed a study in which, with NIH support, we compared live attenuated vaccine with an activated vaccine with laboratory confirmed outcomes in individuals, mainly young individuals, 18 to 49 years of age. And I'll go very quickly through the results because I think the bottom line's what's important. And this was the first year, it was an H3N2 year, and most of the data are for H3N2. And we have in the last columns vaccine efficacy, TIV versus placebo, trivalent influenza vaccine. Now because some are quadrivalent, we're using IIV instead. So what you can see here, if you look at the last column, which is the relative efficacy, how much better is the inactivated than the live attenuated? It was about 50%, and we did it again, and this is showing it's mainly A. We did it again in 2007-8, and we got similar results, showing that inactivated vaccine in adults who've had past experience with lots of influenza strains were protected better. And let's look at PCR positives in terms of the absolute efficacy. It's about 68, 70%, which is what I think the best we can do with a well-matched vaccine in healthy adults right now. That's about as good as it's going to get, and most years is not that good. And this again is for, now what's interesting is the licensure of this vaccine. And to my surprise, in Canada in 2010, Paul, the vaccine was licensed up to 59 years of age. This was several years after we demonstrated that it really wasn't working all that well in young adults. Europe went ahead and licensed to up to the age of 18. Okay, now the up-to-date story, or where we are now with the inactivated vaccine. We used to hear that influenza vaccine was presented 50% of all-cause winter mortality. And all we had to do was get people to get vaccinated, and we would reduce all-cause winter mortality by 50%. These are the studies that Kristen Nickel did. And look at the bottom, the effectiveness. And it was in those older people, and this is older individuals. Now we're moving to older individuals. It was 49% in those with high-risk conditions and 55% in those who did not have high-risk conditions. And what was going on in these days, they were using administrative data. They were looking at illnesses, meeting a case definition during the influenza season. This was mortality. They looked at P&I hospitalizations, they looked at mortality. I'm talking here specifically of mortality. And this is based on who received vaccine from administrative data. They assumed, based on some data which turned out not to be correct, that those who were receiving the vaccine were at greater risk of mortality than those who did not receive the vaccine. In fact, studies were done by Lisa Jackson to show that there were people who were just not getting the vaccine who were at greater risk of mortality. And this was, again, a fallacy. It doesn't mean we shouldn't be using influenza vaccines. It just means that we have no possibility of preventing all 50% of all-cause winter mortality by influenza vaccines. At the time, people shrugged and said, 50%, don't we see that? And there were data presented looking at mortality data, nationwide mortality data, and nobody saw it. And it's the first evidence that we have of the mistake of using non-laboratory confirmed outcomes for influenza. That's the message. Now we have the studies with virologic outcomes to bring us up to date. And we are part of network. You have one here in Australia as well, test negative design, looking at vaccine effectiveness using this design with PCR outcomes. The clear message, and this is the year we at Michigan took the lead in the analysis. And you can see in this year, H3N2 didn't behave all that as well as some of the other viruses. Then the question is, Victoria versus Yamagata. Do we really need a quadrivalent vaccine? These are mainly non-children. The vaccine that year was Victoria. And you can see the protection. And this was the last year we were using only trivalent vaccine. And there's now a paper saying that immune senescence has been exaggerated. Why? We saw failure of vaccines in nursing homes, in older people. The trouble is we were seeing failure of vaccines in all people, and we didn't realize it. So taking 5 years of data, of the CDC data, there is some fall off with age, but the healthy elderly do respond as well or as poorly to our current influenza vaccines as younger individuals. And then our big problem, prior year vaccination. We first saw this in our household study. It is better to be vaccinated than not to be vaccinated. And you can't predict when you're going to be exposed to influenza virus, but it's better to be not vaccinated than the previous year, but you can't say when that's going to be. So it's still best to be vaccinated with influenza. And the reference here is non-vaccinated. And what's interesting is the fact that even prior year vaccination gives you some effectiveness. Waning does occur, but almost all of it is within the first month or two after vaccination. After that, you do get longer term protection. And this is a summary through 2015, and you can see that H3N2 is always the big problem, and the 2014-15 is our last H3N2 mismatch year. We and Australia have just gone through a very big influenza season. Why it's just Australia and the United States, we're not sure. But we're getting towards the end of the same experience you had in your winter past couple of months. And B seems to be working better consistently, 40 to 60%. Okay, genetic group. This is the explanation for the H3N2. It was a 3C2A, and we had a 3C3 in the vaccine. And this is from our friend Dr. Skowronski. And the problem here is that she has been saying that not only does prior year vaccination decrease the effectiveness, but also may increase the likelihood of infection. These are the only data that show that. And it's fortunate that our friends who don't like vaccines haven't really seen the potential consequences of this observation, which I don't think is really has been substantiated elsewhere. This is our network. This is the second year that, or the second year that LAIV didn't work well against H1N1. That's what got this paper into the New England Journal. They wanted to be able to get that message out. And for those of you who want to look back at the Russians, when they developed the first live attenuated vaccine, virus could be recovered from 2 to 4 days with 50% or more of vaccinated subjects who were without antibody. There really is very little rise in antibody titer with this vaccine. Now, for the good news, which we still don't understand, we have been doing test negative design in hospital to prevent hospitalized influenza with our colleagues at Henry Ford Hospital. We are now part of a of a CDC-sponsored network on this, and this was the drifted year. We had mainly 3C2A, very little of matched virus circulating, and look at our effectiveness against H3N2. It turned out to be 46% when it was 9% in the population. We don't understand whether this is methodologic, test negatives. The negatives are different in hospitalized individuals and in the community, but this is one of the few evidences we have for the concept we like to believe in, and that is, even if a vaccine isn't working all that well in preventing simple community-acquired, uncomplicated influenza, it does better in preventing hospitalizations. We are doing a household study to look at transmission, and these are data from prior year vaccination, and it shows what we've known before, that those who get vaccinated year after year really don't respond all that well. As a matter of fact, rise in antibody titer is a negative predictor of protection. It's the GMT, the mean titer, that is a better predictor of protection. And don't forget about the neuraminidase. We have 2 surface antigens of influenza, and we don't have much neuraminidase, if any, in the vaccine. And these are studies we did with CDC, which shows that neuraminidase is a predictor. Now, I'm going to conclude by talking about something which I think is brought up all the time, but nobody really knows exactly what it means, and that's universal influenza vaccination. What is a universal influenza vaccine? And my thesis is that there is a different need for seasonal vaccines and to prevent pandemics. The great goal is having a universal vaccine that will be of long duration and that will protect against drifted strains and therefore will work against a pandemic shifted strain. But we clearly need to increase the efficacy of our current vaccines. With a pandemic, we worry about antigen sparing. We don't worry about that with our regular seasonal vaccines. We do need broadened response. And waning is an issue, especially in place, but it's not that much of an issue. It's much more of an issue if you're going to be preventing childhood deaths in the tropics, because their influenza circulates for very much longer, and this is that their longer duration would be important. But with a pandemic, we do need antigen sparing, and we don't like to have to keep chasing the last variant. NIH in the United States is spending a lot of money making an H7N9 vaccine, testing an H7N9 vaccine for a strain which may never spread outside of China. And this is not very good. But the key element here is for a pandemic vaccine, we would be delighted to accept prevention of severe disease and hospitalization. Is that really a goal for prevention of seasonal disease? Would we be happy if people are still getting sick with influenza after they were vaccinated? My answer to that is no. I think our goals may be different in terms of seasonal universal vaccines and a pandemic universal vaccine. We may get there at some point, but we need solutions and we need them more quickly. Thank you.
Now, that was absolutely impeccable, and you've kept to time brilliantly. I am overwhelmed about the quality and variety of information on influenza which you were able to include in that talk. I know we are supposed to hold questions to the end, but I just wondered if anybody had any specific questions now. Otherwise, we'll move on to hear from Professor Robert Booy, and then we'll ask both of you some questions at the end. Does anyone have any specific questions at this point? I know I would like to ask one. So you talked about what an LAIV needs to actually be successful. Could you give us just a bit of an overview of what the changes to the LAIV are in the US that are bringing it back on to be recommended? And before I pass to you to say that, I would just note for the audience here that, of course, we have recently had LAIV, the Ann Arbor LAIV license in Australia, but it has not been brought to Australia. So it has also not been evaluated yet for inclusion on our national immunisation program. It was licensed right around the time that it was shifted down from being recommended by the ACIP due to that low vaccine effectiveness result that we saw. So perhaps you could just enlighten us a little bit about the changes in LAIV that we hope to see in regard to its use in the US at least.
Well, that is why I decided to spend a little time talking about LAIV, because I realized where you are and where the UK is right now, because as an article of faith, they believe that it is working as part of their very extensive school vaccination program. I think the problem is we are working with a somewhat over-attenuated vaccine. And the dilemma is, if we are now vaccinating, and we're vaccinating 50–60% of children under age 2 years of age with inactivated vaccine. They were the ones that were best protected just during this current H3N2, probably because they were exposed to very similar viruses as the first exposures in life. If you give LAIV to those who have antibody already, the virus does not replicate very well. And I believe that is the explanation for what we're seeing, because all of the initial studies were done with naive individuals. Nobody much was getting influenza vaccine in those days. So we probably do need a less wimpy virus, vaccine virus. The problem is that the H1N1 that they used was clearly not replicating very well. I was surprised at this very severe recommendation that ACIP made to not use the vaccine a few years ago. I was also surprised at the recommendation that was made that it was permissive to use the vaccine, because the data that were shown were that they've now got a better backbone, or a better variant, H1N1 variant, and it is replicating better. And no data on effectiveness, but somebody said, you know, we have in baseball, it's 3 strikes and you're out. We've had 2 strikes already, and at least we'll get some data. We weren't getting any data because it wasn't being used. This coming year, maybe we'll get some data again and see whether the vaccine is really improved. I wish it were. We need various improvements, but my own feeling, having seen the vaccine under development for 30 or 40 years, it's yesterday's vaccine in some ways. We are moving ahead with recombinant and all sorts of other vaccines. And the one thing I do hope we can do is get a vaccine of longer duration, because I believe this repeat vaccination story is real, and I don't understand what's going on. So if we don't have to vaccinate every year, it's going to help us in many different ways.
Thank you. Okay, well, I've got many burning other questions, but in the meantime, I will now take the pleasure of introducing Professor Robert Booy, who's very well known to many of you in the room. Professor Robert Booy is, of course, our Head of Clinical Research at NCIRS. He's got a long-standing interest in diseases such as influenza, RSV, and caused by encapsulated organisms. and has been looking at all sorts of measures, including, of course, vaccines to prevent those. So I'll hand over to Robert.
Thank you. I got this in the mail a couple of days ago from the UNCIRS, and it was really interesting. There was a child's drawing of Mexico, and I was intrigued, and then I saw people trying to escape to Mexico, and I was wondering where they were coming from. Arnold tells me he feels very safe. Arnold tells me he feels very safe here, but the Mexicans tell me they're really pleased that the wall is being built. So there's the summary of my talk in the next 20 or so minutes. And I've chopped half of them out, so I should keep to time. Some of you have seen this already from November last year, the UK news that Aussie flu was coming. Well, it did come, and it may not, it came to the US. And the UK think they've had it bad too, but we'll hear some more about that. It's proving ineffective in the UK against H3, the current vaccine. And it has been compared to previous pandemics, but we know, of course, that New Zealand, Tasmania, WA, Europe itself, continental Europe, hasn't had much H3, so it's hardly a pandemic, but people are calling it the worst outbreak on record. And we know who's most at risk, chronic disease and people at the extremes of life. This is something I took down only last week. Rising UK and US flu deaths, killer pandemic, and a certain expert said that as many as 33 million could be killed in under a year. And it could have an Australian origin. So this certain Jay Quick was reported that the rapidly shape-shifting flu virus is the most diabolic, hardest to control and fastest spreading potential viral killer known to mankind. So that's why you buy newspapers, like the Daily Mail. Michael Osterholm, however, is an American who is held in high regard in the flu field, and he said in January that we're not ready for a flu pandemic, and he's probably right, and I'm echoing what Arnold has said already. In the New York Times, they were reflecting on only 10% vaccine effectiveness being reported from this hemisphere in the New England Journal at the end of last year. And I'd like to make my own reflection on 1940s vaccine research, because we were competing with the Americans at the time, and we were producing a live attenuated influenza virus vaccine. And we were about to test it in the Australian Army when the flu epidemic started in May. It came early. So Macfarlane Burnett, who did win a Nobel Prize, Jonas Salk didn't, by the way, but the Australian did. That's why? Yeah, no, actually he deserved a Nobel Prize, and we'll admire what he did. And as Arnold has said, we need a universal vaccine, and Osterholm said that too. H5N1 is said by some to be the main, but here's some serious work that was published 4 days ago in Science by Seth Barkley, the Vaccine Alliance head. The severity of this year's influenza virus is a reminder of the daunting task facing the global health community, and we could look at how partnerships with industry can be applied to innovative diagnostic technologies, because you can read it. But he reflects not only on flu, Ebola, Zika, yellow fever. All of those are examples where earlier diagnosis in Africa and elsewhere, South America, could have made the outbreaks considerably smaller. So this is what he went on to say: to make these diagnostic tests available and affordable in low-income countries, any delay in diagnosis, reading the last line, will inevitably and increasingly be measured in lives lost. So that's really interesting, because we're actually doing that now in the third world to lesser or greater extents, and we're doing it even here in Australia, where we're hoping to test a portable nucleic acid test in nursing homes, and on the same day that they report an outbreak, test them in the nursing home, have a result within 30 minutes through the gene expert technology, and act straight away that day to control outbreaks of flu in nursing homes here in Sydney. So going back to the epidemiology last year, you probably know it well, so I'll be brief. We had 250,000, and not to use this, we had 250,000 cases reported, and in fact lab confirmed, 3 times the number of the previous year and 4 times the 5-year average. And that red line is 2017. And I like to say this was the both and, or double truth, that we really had more disease and we really had more testing. So we had more detection, and reflecting back on what Seth Barkley said, that we need more detection. Which was more? Well, it's a bit unclear. If you looked in South Australia, New South Wales, Queensland, perhaps Victoria, we had really high rates, but over there in WA, they hardly had a flu season at all. Curious. If we look in New South Wales at not lab confirmed, just respiratory illness or fever or unspecified infection, you see an interesting trend. That is, in black, you see for 2017 that there really was more disease. And this is at the non-specific end. So I think this is consistent with a really bad season and more testing as well. And this is what happened in nursing homes, and this is what caught our attention. Last year, there were nearly 300 outbreaks of influenza in New South Wales institutions, mostly nursing homes. That was in the year before 2017. In 2017, there was nearly 600 with at least 300 deaths. So that's something to pay attention to. And we are paying attention to, working with public health, with virology, with geriatrics, and with other players in the field. Most of the deaths in aged care. This is a difficult slide to make head or tail of. So just look on your right-hand side, and you'll see that H3N2 in the rather murky looking colour of light grey is 47%. So it was the main problem, but we actually had a lot of H1N1, and we had even more of B. So all types and subtypes were causing trouble. And the flu vaccine effectiveness, thanks to Kevin Yin for lending me this slide. If you look again on the right-hand side, 0 effectiveness for all ages against H3 in Australia, and perhaps even worse in people over 65, but not significantly different. So the Chief Medical Officer said, we've got to do something. And I'll let you read that. And we've heard already about egg adaptation. I'm not going to talk about it today because there isn't time. Flicking over to the UK, it was very interesting to look at their mathematical modelling, which can be quite informative, where they said that even under a conservative estimate of effectiveness, an enhanced vaccine would be highly cost effective, 65 to 74 and 75 and above. So there's a bit of what the Chief Medical Officer wanted. So we've just had the busiest season. The current vaccines have reduced effectiveness, and Australia has now introduced 2 enhanced vaccines for better protection this coming season. They'll be implemented next month, we believe. I don't want to take up too much time. We'll just go to the bottom quote from Richard Peabody from the UK last year, saying that in a recent season, 16-17, the effectiveness of vaccine against medically attended laboratory confirmed influenza in primary care in the elderly couldn't be demonstrated. Looking at a meta-analysis going all the way from 2004 to 2015 was also unable in the UK to show significant efficacy or effectiveness rather, for the inactivated flu vaccine in the elderly against AH3. Looking at the bottom comment, above the age of 75, pooled estimates were unable to demonstrate any significant effectiveness across all seasons and all the flu vaccine types. So I accept what Arnold said, if you're a robust, slightly older person like him or I, then you'll respond better. But there are other people who aren't responding well the older they get. So here we have these 2 new vaccines coming. These, just reading again the black, the bold, these TIVs, remember that they're TIVs, not QIVs, interestingly, offer potential increased protection, especially for AH3, which is more common and severe in the elderly. I'll let you read the rest of it if you care to, but in the interests of time, I'll keep going. These are the components of this year's quadrivalent vaccine. The 4th one, the B, is not included in the TIVs, of course. So Brisbane misses out. Timing of vaccination, again, just go to the bold. Optimal protection occurs within 3 to 4 months. So there's a feeling that if you vaccinate the elderly, perhaps late April and May, you'll get better protection than if you vaccinate them in May, early April. Here's an important point that's going to be promulgated this year. Revaccination later in the same season, if people have already had vaccine, is not recommended, but it's not contraindicated. So have a think about that. Pregnant women, it's recommended every pregnancy. Again, let's go through the bold. Protection to the infant occurs as well. And the 2018 vaccine can be given to a pregnant woman, even if they've had the 2017 one already. So another thing to think about. Nearly finished. Our annual flu vaccination is recommended, but it's not NIP funded for healthy people who are over 6 months of age. Those are the lists that we all know very well. There's no way I'm going to read them out to you. In the UK, just to flick back for a moment, the JCVI has recommended that people 65 and above should get an adjuvanted TIV, and younger patients be offered the QIV. Use of these more effective vaccines only will occur in 2018-19. So we're leading the world here with using both adjuvanted vaccines. Europe's used one, US has used the other, but we're now about to use both. February 2018, this is a slide from the US, hospitalizations for flu-like illness were at their highest since CDC began collecting data. So that looked bad to me. It was reported that as of this week, overall hospitalizations are now the highest we've seen, even higher than the mismatched year of 2014-15, due to a drift variant H3N2, which we can discuss later. I don't have time now. And just a couple more comments about, we've heard about a universal vaccine. What else have we got? Well, we also have a pneumococcal vaccine, an encapsulated organism called a bacterium, which often complicates the influenza infection. And CDC is concerned that the current vaccine's effectiveness against H3 is lower than against other types and than in recent years. And so here's a way we could better protect the elderly by ensuring they have their routine five-yearly pneumococcal if they're at high risk, or at least one dose if they are robust and older. Okay. So, in fact, having reviewed just a month ago here in Australia, in Melbourne, the 1918 pandemic, it's speculated that perhaps more than half of the deaths were due to secondary bacterial infection. But the vaccine produced in 1918 by CSL actually was made up of 4 different bacteria, depending on which one you got. So it appeared to have some benefit. 2 more comments before I finish. In the UK, in January, health officials were calling for a serious debate about mandatory flu jabs for NHS staff. I just raise that and leave it there in case you want to discuss it. And then I point to, it's not just vaccines, it's antivirals that we mentioned earlier for nursing homes, and it's also infection control, isolation and school closure, for example. And just a month ago, the Hong Kong government was closing all kindergartens and primary schools early for Chinese New Year because they already had an outbreak. So there are more than immunizations used to control influenza. Cut off the chain of protection, as I said. And the international perspective is always worth coming back to. And in conclusion, all countries, rich or small, if they work together to control flu outbreaks and build capacity to make better vaccines and respond earlier to outbreaks, and strengthen health systems, then we've got a chance of controlling flu at regional, national and multinational levels. Thanks very much.
Okay, well, Robert, thank you very much. Why don't you stay up here? And Professor Monto, if you wouldn't mind coming up as well. Look, I am conscious that we're having this influenza as the topic of our symposium. In fact, before the detailed materials have been released from the Commonwealth and Health Departments on the actual vaccines in use for this year. So they're about to come out, we hope, any day now. And I'm sure as there are, members of New South Wales Health and other department members on the line, we're all looking forward to seeing those materials. But I would say one of the striking differences that we're heading into this year is the availability of these 2 new vaccines, only registered in the over 65, as Robert's alluded to, and they're quite different. So, one still has just 15 micrograms of the hemagglutinin, but has a powerful MF59 adjuvant. The other actually has 4 times the amount of hemagglutinin, so 60 micrograms for each of those 3 strains of hemagglutinin, but no adjuvant. So in very different ways, they are providing a bigger kick to the immune system and a jolt, which gives them what we think, at least with pretty good comparative clinical trial data with respect to the high dose, is about a 20 to 25% advantage over the standard TIVs. Now, Robert's mentioned these, and Professor Monto, knowing that the US has done some sizable studies of the high-dose vaccine and indeed been using it now for a few years, could you comment on what we might expect to see, given that we have both of these new vaccines coming to us in Australia this winter?
First, I'm delighted that you will be able to do more or less the head-to-head comparison of the two, because it will not take place elsewhere for all sorts of reasons. We've been using the high-dose vaccine in the United States for several years. Direct studies have shown advantage for H3N2, for B. This is for uncomplicated influenza in randomized control trials. So our colleagues who will only believe data from randomized control trials will be happy about that. They have not shown advantage for B. Other observational studies using the Social Security system and the rest have shown greater prevention of hospitalizations and indeed death with the high-dose vaccine. The problem with the adjuvanted vaccine is that the randomized control trial is being done against placebo. There is no direct comparison of the adjuvanted vaccine in a randomized control trial with inactivated vaccine. I don't know if there needs to be, but your head-to-head comparison gives the opportunity for the world to be able to see this. In the US, our observational studies are probably at the end of this flu season going to be able to say something about high dose versus regular. I think there's enough high dose being used in the US now that in observational studies, we're captive to whatever's used. And there's enough being used, so we're going to be able to say something about high dose versus regular dose, but we're not going to be able to say anything about the adjuvanted. And I think the other thing, the other advantage the adjuvanted vaccine may be giving is if there's drift, it may protect better against drift. There's no good evidence that the high dose will protect better against drift.
The issue we have is that we've got 2 new, let's call them enhanced vaccines, and we have to manage public health expectation and GPs and the like. And it's very important to say we actually don't know the difference between them. We think they're both better, therefore use either interchangeably. And if we start focusing on one or the other as being better, it will create problems out there in practical GP and practice nurse land. The other thing worth saying is that, and it's really important to emphasize, is that we talk about both of them being about a quarter better. So if you think you've got a baseline of 25%, a quarter better, okay, so it goes up to 50%. No, it doesn't. It's a quarter of 25. It goes up to 31%.
My name's Paul Van Byne. I'm a public health physician on the Gold Coast. And I mean, I'm biased one way because I studied one of the 2. I think you're right that if there's a drift season, it might be better. I think the RCT showed the high dose didn't do as well in the drift that year as it did against the others. I actually think it's not 25% of the current, it's actually an additional process. If you look at the relative attributable increases, they're actually total numbers, not, they're 60% to 30, not 37% to 30 in a number of the studies that have been out there. So Robert and I can debate that later. What I'm interested in is that what seems to be a disconnect to me between waning over the course of an individual winter, whether that's waning in antibody plus some drift through the season or what the combination is, but then a concern that residual protection from previous years is interfering with vaccine in a subsequent year. Because it seems to me, if it's not working anymore in that year, why it interferes with the next vaccine? I just wondered whether you had an explanation for where that's coming from.
I will defer to B-cell immunologists who have all sorts of explanations, sometimes conflicting, about the repeat vaccination phenomenon. I think we've seen it repeated enough to believe that it is a real phenomenon with type A. It may have something to do with imprinting. It may have something to do with what was originally called original antigenic sin by Francis 40 years ago. Flu is extremely difficult to study and to evaluate. And not being a molecular virologist, I give over to my colleagues who always have an explanation until next year when, when it doesn't work all that well. Clearly, egg adaptation is the major problem we are having in the US with the vaccine this year. CDC is on record as saying there isn't that much drift, but I cannot accept the fact that it's all egg adaptation with H3N2 giving us 25% effectiveness, and 2 weeks before it was 9. Fortunately, it went up to 25 when more of the data kept coming in, and that's the danger with interim assessments, because the numbers are bouncing around, and it'll be very interesting to hear what the final estimates are from this past year.
Well, I know that I don't think Australia's published their final estimates yet either. So and everybody always feels a little nervous about those interim estimates. But I'm going to take the chair's prerogative. We've still got a few more minutes. But Robert, with your paediatrician hat on, you know, we have now 5 states. They're all states, aren't they? I think, or 1 territory. 4 states and 1 territory in Australia that will have paediatric programs. So with free inactivated quadrivalent influenza vaccine for use in children 6 months to under 5 years. Of course, we can look to the WA experience, and Paul Van Binder has already spoken, is here in the room, and he was instrumental in introducing that program from 2008 onwards in WA. But what will we be able to do this year, given that we have programs in more than half the population in children under 5?
Well, I think it's more than that. In South Australia, the Labor government has already promised, if they win, that they'll have flu vaccination. And that leaves only 1 state, which no one's much heard of, called Tasmania. And they're so isolated they don't get much influenza. So most of the country, the mainland, as the UK like to call themselves, the mainland will have vaccination. And so we've got tremendous opportunity to evaluate the effectiveness in the field of quadrivalent vaccine. So I think that's really great. And given the setup that's here and across the country with paediatric active enhanced disease surveillance, we'll be able to capture cases and do test negative analysis. Now, you did say that the Australian estimate was interim. It was good enough to get into the New England Journal and when it was published in October, November last year. So it's going to have to be great when we get the final result.
And I was called upon to comment on that for National Public Radio in the United States, and was called back by the reporter because I disagreed with an article written by people from Melbourne, but also from Tony Fauci, the director of the National Allergy and Infectious Diseases Institute, when I said it might be closer to 30%, because this was egg adaptation and not simply what we were having was egg adaptation and not drift. I'm glad it was closer to 30% than 10%. But the 10% estimate, when the press ate that up, not only that, we had to do a repair job to get vaccination programs to keep them going. We have a difficult job right now with the current situation. And I admire everybody who is trying to deliver the message that we really need to keep vaccines being used, that the community effects are there, even though the individual effects may not be as robust as we thought they were.
Very well said. Now, I'm conscious, Sarah Sheridan, do you have a question? If you can shout it out. So I'm just going to repeat the question for the audience. How important do we think vaccinating young children is for herd protection?
Having written the paper in the pandemic before that about vaccinating school-age children, I think it's very important. The big question is how effective the vaccines have to be in order to get them to get the herd effect. You are getting a herd effect, but the debate has always been how effective do these vaccines actually have to be. In some ways, a live attenuated vaccine might be better. And I think that's why the UK is proceeding with a live attenuated vaccine, because it will affect shedding more than the inactivated vaccines, even when there is failure. But I am glad that the UK is now doing a better job of evaluating the effect of their vaccine program. It's one of these situations where, and the same thing happened in Ontario and Canada, where they made vaccine available to everybody and forgot to appropriate money to evaluate how it was working. I think that is the critical thing here when you have a unique opportunity to compare two important vaccines for older individuals.
Paul, I'm going to defer to anyone else before you, just to give anyone else a chance in the room to ask a question. Not that I'm being mean, but yeah. Okay, I'll pop Paul.
I just want to make a couple of quick comments about that. The monovalent adjuvanted vaccine used in Canada was preferentially used in children early on. And when we, at about week 2, week 3, got 65% of children vaccinated, the pandemic second phase stopped because of the herd impact of getting so many children. The reproductive number for influenza remains very low compared to aerosol viruses. And what Mark Loeb showed, but what Richard Pepperty is showing already in England, with a 40% uptake, with a vaccine that's only working at about 40%, they're getting herd impacts in the UK from that sort of number, which just reflects the fact that at an R0 of 1.5 or 2, you actually don't need measles-like coverage to have the herd impact that they're seeing.
Do we have any more questions from anyone here in the room? We've got a lovely audience who I've hogged all the questions, so I've got to ask if anyone else would like to ask something before we wrap up and thank our speakers. No. Okay. Well, given that we are then a few minutes over, it has been an absolute pleasure, Professor Monto, to hear you speak today, and Professor Booy as well. Thank you so much for your fantastic insights, and we're very grateful. Thank you.